In this video, we will examine what occurred and what was said when Liz Hull and Caroline Cheetham interviewed Dr. John Gibbs from the Countess of Chester Hospital in their podcast series shortly after the conviction of Lucy Letby was announced. In this video, so the podcast begins. I'm Liz Hull, Northern correspondent for the Mail. I've been in court throughout and have reported on the case as it developed. So I'm going to let her off talking about being in court in this case because she actually doesn't talk about it as much as she usually does. And Caroline Cheetham says, and I'm Caroline Cheetham, a broadcast journalist. Every week we've examined what's happened and brought you the details behind the headlines. So here's a great statement to begin with. So Liz, since we announced all the verdicts in this case a week ago today, so yeah, they announced the verdicts. Who needs to judge? Because they were on hand to announce all the verdicts to an expectant public. Actually, a lot has come out about things in this trial that we had heard, things in this trial that we hadn't heard specifically. So that's just her missing a speech. An awful lot now has been said about the behaviour of hospital management and what was going on that ward. So specifically, Caroline, we hadn't really heard from the managers of the hospital. They did not give evidence at the trial because it was deemed not relevant to, obviously, the evidence of how or when the babies were harmed. In this video, so Liz says here that the court didn't hear from the managers and they didn't give evidence at the trial because it was deemed not relevant. So I'll also just briefly mention that the court also didn't hear from the Royal College in its report, even though this is referenced later on more than one occasion during this podcast. So this is critical context that was removed or excluded, I should say, from the trial. Very difficult to understand why that would be the case. As she states here, we didn't hear from the managers because it wasn't deemed relevant. She doesn't question that in any way. She doesn't critique that. And of course they never mention that the RCPCH report wasn't part of the trial, and other things that provide important context were also excluded from the trial. It's possible Liz doesn't understand this. However, we do understand it. We do know how important this report is. Ask any medical professional, they will tell you, and clearly it should have been part of the court case. So I wanted to mention that before we go any further. In this video, so Liz continues, but a lot has come out of the woodwork since the verdicts. Several of the senior consultants who worked at the hospital have been speaking to the media, really outlining in quite a lot of detail the timeline of what happened when Lucy Letby was moved off the unit. We know she put a grievance in September, then that rolled on to December. So we'll just mention at this point that, as you can see on the screen now, if you're watching the video, Lucy's grievance, as has been well established, was upheld on all 7 points. This was, again, something that was excluded from the court case. It's quite possible that at this time Liz Hull didn't know that. In fact, it's quite possible that she doesn't know that today, seeing as she does no research about the case whatsoever. So all 7 points of the grievance were upheld. Because of what I've outlined in the timeline videos that I've made previously, we know for a fact that it was absolutely correct that this grievance procedure was upheld. Of course, it was run independently. It was not an internal hospital process or procedure. It was run by independent people. So we'll go back to the transcript again. We knew she was due back on the ward in March, and for whatever reason that happened and the police were called in May 2017. But we didn't really know the ins and outs, who did what, who emailed who, and that is really what has come out over the past few days. And quite frankly, a lot of it has been pretty shocking about what happened. And then Caroline Cheetham says, significantly for this episode, we were really lucky that Dr. John Gibbs, who was one of those senior consultants on the ward, shared the concerns of 6 other consultants, including Dr. Ravi Jayaram and Dr. Stephen Brearey and a number of others who were, knocking on management doors to say, we're worried, we're concerned. And I think that while no one wanted to jump to conclusions, call the police in rashly, or accuse somebody with absolutely no evidence unfairly, they were not listened to. And you talked about, Liz, about the timeline. Everything took forever. So, speaking of the timeline, let's go back and remind ourselves about what we already know about what occurred with the investigation, what occurred with the police, and what occurred behind the scenes on this unit. In this video, so the first thing to say is that it's suggested here that no one wanted to jump to conclusions or call the police in rashly or accuse somebody with absolutely no evidence unfairly. So we know how ironic these words are now. But the first thing is, already on the 22nd of June, they're talking about a commonality with a member of staff. So if it had been 15 days before this, it would have completely preceded any incidents on the unit. That's how early it was. It was within 2 weeks of the first problem on the unit, the first infant that passed away. So to say that they didn't want to jump to conclusions, Stephen Brearey absolutely had suspicions or believed that they should be looking at commonality with nurses immediately. That was the first thing he did. We see this further emphasised in July when Stephen Brearey again picked out a commonality with Lucy, as reported by Yvonne Griffiths in a June 2020 interview. Then by October of that year, which is 2015, Stephen Brearey spoke to Yvonne Griffiths again, expressing his concern that Lucy seems to be the common denominator. Yvonne Griffiths moves Lucy Letby to days to stop finger pointing, not because of doubts about Lucy. And then, as we know, there was never any evidence. They never presented any evidence, and even by May of 2016, after a neonatal unit review by Ariane Powell, there's no evidence whatsoever against Lucy Letby other than coincidence. And then, of course, we know the case was passed to the police, and on the 5th of May, when the first meeting of Operation Hummingbird took place, the police document talks about the statistical relationship, coincidental relationship between Lucy Letby and collapses, and states there is no evidence other than coincidence. And then we see on the 12th of May, the police say at present there does not appear to be any evidence of a criminal wrongdoing which would warrant a police-led criminal investigation. So despite the fact that they supposedly didn't want to call the police in rashly and didn't want to accuse somebody with absolutely no evidence unfairly, when the case was actually referred to the police, which was what the consultants, particularly Dr. Brearey, had wanted for quite some time, as we'll see later in this video, at the time that it was eventually referred to the police, there was, as Caroline literally expressed it herself, absolutely no evidence. They literally used the phrase, there is no evidence. In this video, so then Liz Hill says the following. I mean, the really crucial point I think that comes out of our interview with Dr. Gibbs is that the management tried everything not to go to the police. Everything. So in a sense that's true, because they should have gone to the police given that they wanted this to happen, but none of them actually had the courage to do it. And indeed, when it was finally referred to the police, it was nothing to do with the consultants. Of course, Dr. Brearey and Dr. Jayaram managed to turn up and speak to the police and then seed them with a load of inaccurate information. But they couldn't refer the case to the police because they didn't have the courage to be a whistleblower, and they also didn't want themselves to be in the firing line. Basically, the reason they handled it the way that they did was due to a complete lack of courage. It's not true that they didn't want the police to be involved. They absolutely did want the police to be involved. They just didn't want to be the ones that had to make the actual referral. So they did everything possible to make sure it was referred to the police while risking absolutely nothing themselves, which is why Eileen Chubb of the Compassion in Care whistleblowing charity has stated quite explicitly that they're not whistleblowers. So let's continue with the podcast. So they were appointing experts to do independent reviews, asking the Royal College to come in, appointing another expert to do another review. Caroline Cheetham. The reviews, as you'll hear, were covering medical problems, and it needed detectives. It needed police. So I have always questioned and always challenged this assumption. I can still see no reason why you would believe that the police were the best people to conduct what Dr. Jayaram in the 15th of May meeting describes himself as a multidisciplinary review. It's very clear now that we've been over quite a bit of information related to the police and we've started to look through the Hummingbird video. It's quite clear the police didn't have the slightest clue what they were doing, and they had no idea how to run a multidisciplinary review. In fact, now that we've spoken to Stephanie Davies, we know that basically even her comments where she'd been asked to review the cases, even her comments were misinterpreted. So the police were a million miles out of their depth, And as for this assertion that's made here that it needed police, it needed detectives, what it needed was a medical review. In fact, there had been medical reviews. It could have been stated with some legitimacy, a lot of legitimacy, I would say, that the medical reviews had already indicated that there was no malfeasance. But if that wasn't satisfactory to the consultants, which it obviously wasn't, then they should have sought a medical investigation. Perhaps, if you were being generous, you could say that they were naive about the ability of the police to run and deal with this, and they perhaps thought the police would do a better job. That's the most generous interpretation that you could possibly make of why they were so desperate for the police to be involved. Because they genuinely believed the police were the best people to do it for some reason, and that could involve some degree of naivety on their part. That's the most generous thing that I can possibly say. I'm sure others will have less generous interpretations. So Caroline continues, so it was no surprise in the end that none of those reviews found anything because that wasn't their expertise. So this is an incredible statement, really, from Caroline, suggesting that they've got a neonatologist, they've got a pathologist, they've got a coroner. They do this kind of work all the time. It's literally their job. But according to Caroline, it's not surprising that these medical reviews didn't find any issues because it's not their expertise to look at any of these things, although actually it is their expertise. And what she's suggesting here is that somehow the police had better expertise to be able to investigate these things than the medical people that investigated the causes of death. I'm not sure what she thinks happens when a pathologist investigates or examines an infant. I'm not sure what she thinks coroners do, but what they essentially do is decide why an infant has died. That's what they do all the time. They don't do anything else. So why she would think the police were better placed to understand that and better placed to investigate that than literally a group of people whose only job is to investigate medically why someone has died, I have no idea. But obviously this is one of her more abjectly stupid statements. So then Liz Hull continues, no, and they had the wrong remit. And each time these reviews were presented to the consultants, they were still left scratching their heads saying, well, that's all very well and good. This review's picked up X, Y, Z, but it hasn't addressed our fundamental concern that there could be a member of staff that's responsible for these deaths and collapse. So let me explain this to you, Liz, so you understand. Tricky one for you, but maybe you'll see this one day and, maybe you'll try to engage your brain cells. So their job is not to address what the consultants have said and make the consultants happy. Their job is to look at the infants, examine the medical conditions, examine what can be extracted from medical documents, I should imagine, and they're supposed to dispassionately examine what has occurred to the infant. It's not their job to say, right, well, there are some suspicions on behalf of the consultant, so let's take that into consideration and let's make sure they're happy. Absolutely ridiculous. Of course, that's another obvious source of bias in this already chronically biased process. The pathology, coroner and neonatology review from Dr. Jane Holden, that's pretty much the only objective part of this whole story. And they examined the infants and they did what they usually do and they couldn't see any evidence of malfeasance. And we know why there's no evidence of malfeasance now, because the notes have been examined by some of the best people in the world, and as they announced at the February press conference, there were no crimes, we found no evidence of crimes at this hospital. In this video, we will examine, so we'll continue with the podcast. Caroline Cheetham speaks next. What you're going to hear from Dr. John Gibbs is his account of what he witnessed over months and months working on the ward. He'll talk about a toxic culture. He'll talk about rifts between management consultants and, in the end, nurses. He'll talk about his own huge regrets that he wishes he'd done more. So here's that interview. So Caroline Cheetham begins the interview. Liz, we're joined by Dr. John Gibbs, retired paediatrician from the Countess of Chester Hospital, one of the consultants who was working on the ward at the time when Lucy Letby was attacking patients and desperately tried to do something about it. And Liz says, we're really pleased that Dr. Gibbs is here today to talk to us. I will say that I'm not going to pick them up on every single factual inaccuracy. Dr. Gibbs wasn't really the person who most desperately tried to do something, but let's allow that to slide. It's fascinating to have someone that was so close to what was going on to chat to, so thanks so much for coming in. Thank you. Can I ask you first, John, any reaction to the verdicts? We're talking to you in the hours after the verdicts because we wanted to wait and talk to you after that to see what your reaction would be. I suppose for some of the families and for many families it's bittersweet, as the police said, because there's some level of justice, but it also makes it true. Incredible. This is an incredible statement at the end of this. So we know that these two love the court. We've established that in previous episodes where we've looked at the podcasts. According to Caroline, when something happens in court, it makes it true. So that would obviously mean that if there had been a different verdict, what happened in actual reality would change. So if she'd have been found not guilty, that would have then made it false. So what actually happened in the hospital would literally transmogrify because of what occurred in the court. This is what I mean about these people. They're obsessed with authority and the authorities and the establishment and power, I suppose. And they just bow down before it. Just because there's a courtroom and some people walk in and say stuff, it doesn't make it true when there's a verdict at the end of it by just some randomly selected people who were sat in the jury. It doesn't make it true. The only thing that determines that is what happened in actual reality. If the verdict had been different, the actual events in the hospital don't change. If Lucy Letby had been found guilty of the other infants that she wasn't found guilty of, again, the incidents in the hospital don't change. If she'd been found not guilty of some of these infants, less than she was, but was still found guilty of some, again, what occurred in the hospital never changes. It cannot become true because of a verdict by a jury. She's been found guilty and she has to go to prison, but that has no impact on the real world events. It's also notable here that Caroline says, we're talking to you in the hours after the verdicts because we wanted to wait and talk to you after that to see what your reaction would be. Now, we know that some of the verdicts were leaked to the press and leaked to members of the media before they were announced in court. It seems very clear that Caroline and Liz were among these people. We know about the payment from the Cheshire Constabulary. We know about their potential bias. We know that they're probably among the approved journalists. We know they were probably at this pre-trial press conference. We know that they kept up a relentless guilty narrative throughout their entire podcast and through everything that Liz has written in the Daily Mail. So for me, it would be considered quite worrying that we're just waiting for the verdicts to come out. Of course, we know what the verdicts were, but we just wanted to wait until they came out so that we could talk to you. We knew that we needed to talk to you because we already knew what was going to be said. That's the implication by her words there. So Dr. John Gibbs responds to this. Yes, well, very much. Mixed emotions, some relief that eventually, after a very long trial, the jury have come to conclusions. They're always going to come to conclusions, John. They can't. I mean, I suppose they could have a no verdict on everything. But I mean, it's very, very likely that we'd come to conclusions. And also that in most cases, they managed to come to a conclusion on most of the babies. The truth is now out. Not really, John. It's just a court verdict. The jury have determined the truth. Again, I mean, it's incredible. Like just, seconds ago, they were saying the pathologist and the coroners are not trained to do their job. I mean, they've got no idea about how to do what they've been asked to do. They can't do that. But here we're imbuing the jury with like supernatural ability to determine the truth. Like, incredible what juries can do. They have to sit in court and deal with these incredible, diverse range of extremely complex subjects with an immense amount of information. And in this case, it's an extraordinary amount of information across multiple subjects. But the jury are just random people who get a letter through the post. They can just sit there and just determine the truth by sitting there and listening, as he describes it. An extraordinary disconnect from the reality of what actually happens in court. And I accept that there have to be court cases. They're never going to be perfect. I'm realistic about that. But to say that the jury can just determine the truth, is, in my view, it's just a statement that has no credibility. Having listened and spent a lot of time contemplating the huge amount of evidence that they've heard over 9 months, and also a sort of grim satisfaction that the serious suspicions that we paediatricians had about what Lucy Letby we felt might be or probably was doing on the unit have now been confirmed. But of course, it's devastating for the families. It's probably particularly difficult, though, for the families where the jury decided, quite understandably, given the complex nature of the cases, that for a few of the babies, I think 4, they could not come to a definite verdict. So, I mean, that's a fair comment, but the question would be, John, if the cases are complex, as you acknowledge, and if it's quite understandable that they couldn't reach a verdict in these cases, why is it to be celebrated that they came to conclusions in other cases? How is it that you're certain, if they don't come to a conclusion, you're certain that's the right decision, and if they do come to a conclusion, that's also the right decision? How are you so certain of that? Anyway, we'll move on to the next statement, which is from Caroline Cheetham. Still no answers for those babies. Can we go back to, well, there is an answer, Caroline. There's a no verdict in court. So effectively, Lucy Letby is not guilty. Can we go back to June 2015? Between June 2015 and July 2015, there were 3 deaths. Can you just give us some sense of how that is an unusually high number? Well, on a neonatal unit like ours in a district general hospital, and we have about 3,000 deliveries a year, 300 to 400 patients get admitted to the neonatal unit. Some just briefly, some stay many weeks on the unit. We would normally expect anywhere between 0 to 6 deaths, but usually 2 to 4 deaths a year. To have 3 deaths within just over a month is unusual. That's roughly what we'd expect in a year. And we did think, is there an underlying cause? And at that time it was something like, is there a strange infection in the unit? But those babies didn't all have an infection associated with their deaths, and certainly didn't have the same infection. If they did, then you'd be wondering, is there some contamination somewhere in the unit? You do worry when you get a little flurry of deaths, but as long as it doesn't continue, that might still be normal. It's because it continued over the year that we became very worried. So there's a few things to say about this, so let's just break it down. The first thing to say is that it's reasonable to say that 3 deaths in a period of 2 weeks is unusual, and it's absolutely correct for them to assess this. Of course it is. But as I've mentioned previously, Dr. Brearey in particular immediately started looking for a nurse commonality and then became completely obsessed with it. That's very clear. Now, I know other people think that Lucy was deliberately targeted. I still don't believe that, but I accept that it's a possibility. I don't think that's the case because they couldn't have known what was going to happen. And also, if there was this kind of deliberate aspect to it, then they would have been very unwise to write down as much as they did that we now know because of the Thirlwell inquiry, and there's probably stuff that we still don't know. But we know a hell of a lot because they wrote so much stuff down. So I think if there was a deliberate targeting, that just wouldn't happen. But what we can say is that Stephen Brearey was fixated on Lucy Letby, on nurses, on commonality, basically immediately. So that's the first thing to say. With regard to these things about infections, I don't think anyone is suggesting, well, I've not encountered anyone who's suggesting that infections can account for everything that occurred on the unit. I don't think anyone reasonably believes that, but they can be a contributing factor along with the other things that we're going to discuss later in this video that we've been over many times. We're going to go over them as briefly as possible in this video because I don't want to go over them all in depth over again. But what I do want to go over at this point is the 3 children that died between the 8th of June and the 22nd of June and the circumstances that surrounded these deaths. In this video we're not going to go through all of the details of Child A, Child C and Child D. We're just going to look at some of the mistakes, and even this is not exhaustive, but some of the mistakes that were made in the hospital. So firstly with Child A, the post-mortem of Child A showed a recent non-occluding thrombus in the liver, which means there was a recent thrombotic event. So essentially they just missed this completely. On the day of collapse, Child A had 2 central catheters that were left without infusion for up to 4 hours, which predisposed to thrombosis when there is no infusion. So that was a major blunder. Shortly after infusion was started in the most central line, Child A collapsed. A thrombus from the catheter tip likely migrated to an artery supplying the brainstem, causing sudden collapse and inability to resuscitate the infant. So these were pretty serious mistakes that were made, although it's nothing compared to Child C and Child D. We should also say about Child A that this was an infant that shouldn't have been delivered at a non-tertiary unit. We've seen in previous videos that Lucy Letby fought very strongly for one parent to have their child transferred to a tertiary unit because she felt that was the right thing to do. As I've pointed out at times, is hardly the behaviour of someone that murders babies or wishes to harm babies. But there were several infants on this unit that were born there that should not have been born there, that should have been born on a tertiary unit. That's even if they weren't downgraded. Of course, now they've been downgraded to a level 1 unit. They were an inadequate level 2 unit, so that makes it even worse. So we'll move on here to Child C. Child C showed multiple clinical signs of intermittent bowel obstruction, no bowel opening from birth, dark bilious aspirates, bilious vomit, intermittent stomach and small bowel distension, recurrent crying. No bowel movements and dark bowel aspirates and vomiting are clear indication for urgent surgical opinion. This did not occur. So this is, in my view, a pretty major blunder, because these are very clear physical signs. They should know that this is a sign of a bowel obstruction. I mean, frankly, it's not mentioned in this particular passage as well. There's no passage of meconium. These should be really obvious things for paediatrics and for a unit that is purportedly able to deal with neonates and premature babies. If they can't recognise this and they can't deal with this, then it's not particularly surprising that they encounter problems. And then it continues. 2 nurses commenced resuscitation, one of whom was extremely inexperienced and had never done cardiac compressions before. The medical registrar who was called had 3 unsuccessful attempts at intubation before the consultant arrived. Child C therefore would appear to have had ineffective ventilation for at least 20 minutes, which would have resulted in marked respiratory and metabolic acidosis and made subsequent resuscitative efforts less likely to be successful. Child C then did not respond adequately to prolonged resuscitation because of inadequate resuscitation for 20 minutes following an acute episode of apnea. So not only do we see numerous mistakes with this infant, but the infant ultimately died because of a decision to discontinue respiratory support and resuscitative effort in the face of a poor response following inadequate resuscitation for at least 20 minutes after an acute episode of apnea. The clear prior signs of intermittent bowel obstruction that warranted urgent surgical opinion and investigation had gone unrecognised. And not only that, but as we can see from this record of the court proceedings, Dr. John Gibbs gave evidence on the 31st of October and the 1st of November during the court case on Child C because he was around at the time of the demise of this infant. Now we'll move on to Child D. So Child D was electively intubated after 3 attempts and ventilated. The mother of Child D should have been given antenatal antibiotics for prolonged premature rupture of membranes in a preterm infant. Admission to the neonatal intensive care unit, blood gas and CPAP were delayed for 3 to 4 hours, and chest x-ray was delayed for 6 hours, which subjected the infant to unnecessary acidosis, high CO2 and delay of antibiotic treatment. Yet more major mistakes made here. The infant continued to deteriorate after admission and showed signs of worsening infection with fever, intolerance of CPAP removal, deteriorating blood gases, increased metabolic acidosis, raised CRP, and repeated episodes of apnea and desaturation. So the ultimate conclusion is the mother should have received intrapartum antibiotics, and there was delay in recognising respiratory distress after birth and starting antibiotics and treatment. So we see across these 3 infants that all sadly passed away that many very fundamental mistakes were made by the hospital, and that in at least one of these cases the infant shouldn't have been in the hospital to begin with. They should have been in a tertiary unit. So with Dr. Gibbs is saying there in his previous statement as this podcast, we had no idea. We had no idea what was going on. We couldn't see any problems, but they simply didn't recognise their own mistakes, which is not surprising because they wouldn't have made those mistakes deliberately. They're trying the best that they can for the infants. They just made some very bad mistakes. There were very bad mistakes in treatment. There were very bad mistakes in diagnosis. And that has ultimately compounded at least one infant that shouldn't be on the unit. And I think if you're to assess the full circumstances of Child C, that infant ideally wouldn't have been treated at the Countess of Chester either. So when Dr. John Gibbs is stating in this interview, there was a few problems on the unit, but nothing too much to worry about as far as we were concerned, when you actually get real experts looking at the notes, they find an absolute litany of problems. And this, I should emphasise once again, this is not an exhaustive record, even of what we've got in the preview of this longer expert panel report. The longer expert panel report no doubt will have more detail on the mistakes and list more mistakes. And even then, I'm not even going over all the mistakes that are in the preview report. There were a lot of errors made on this unit by doctors, including Dr. John Gibbs. And understandably, at this point in time, before he'd seen all the panel information, he's essentially saying he's hand-waving the problems on the unit. He's hand-waving the infection. He obviously doesn't mention any medical errors at all, but it's very clear that there were medical errors made. And this is ultimately why these infants are sadly demised, not because of Lucy Letby. In this video, so Liz Hull continues. But that's why Stephen Brearey decided, or kept pushing and thinking, oh well, this needs looking at. I think he asked Iriam Powell, the manager of the neonatal unit, to look at the staffing at that stage, and that's when the first association with Letby was first flagged, I suppose, but not really taken seriously at that point, and Dr. John Gibbs says. There's some overlap in this transcription where the transcription service hasn't quite got things right. I tried to put this through 2 platforms, so I'm sorry if there's small mistakes, but I really couldn't go through listening to the whole podcast and transcribing it myself. No, I think it was noted at that time that Lucy Letby had been involved with all of those deaths. Generally, when we're reviewing deaths of patients in the hospital, and in particular, in this case, neonates on the neonatal unit, we're not really looking at staffing levels because we don't expect a member of staff to be doing anything unusual. So it should firstly be noted that there's an incorrect statement here from Gibbs where he says that Lucy Letby had been involved with all of the deaths. So it was noted at the time that she'd been on duty for many collapses, but not all of them. It's only later they managed to wangle it so that she was on duty all the time. In terms of looking at staffing levels, perhaps what they should have been looking at was their own staffing levels and their own ability to staff the unit, rather than who was on duty and whether there was a commonality, which was immediately the first thing that Stephen Brearey did. And I think it was the various people, the different consultants, and it was the different consultants for those early babies who were called in on or around the time the babies collapsed and tried to resuscitate them unsuccessfully. For the babies who died, who noticed that Lucy Letby was there, and then someone else noticed Lucy Letby there, and then another consultant noticed Lucy Letby there, we do talk to each other because when a baby dies, we review those deaths. We want to know, is there anything we could have done differently? And we're thinking about ordinary clinical care. Did we follow guidelines properly? Did we diagnose everything that was wrong with the baby? And it was through that it was noticed that Lucy Letby was there each time. So actually what he has described there is what consultants should do, of course. And it seems that there were some attempts to do this, and we can actually see this in documents of the time. The problem is that they were unable to identify or recognise or perhaps acknowledge any of their mistakes, seemingly, but they did notice that Lucy was there. So instead of thinking, should we examine this further, and that would have obviously been much, much harder. It would have been much, much harder for them on numerous levels to examine their own practice and examine whether or not there were mistakes on the unit. There are numerous self-serving reasons why they would want to do that. And then also just from a logistical and practical perspective, it's much harder. It's much harder to deeply educate yourself in problems related to paediatrics and neonatology than it is to say, oh, there's a nurse all the time, that's strange, shall we investigate this a bit further? That's very easy to investigate. It requires no intelligence, it requires no ability to address that. And as we know, I don't believe Lucy's been deliberately fitted up in this case, but it's as close as you could come to that without it actually happening, because what this case demonstrates is how you can build a case against someone and make it look very damning, but actually the constituent parts of that case have absolutely no substance whatsoever. So essentially, there has been a period of reflection, which is exactly what you'd expect, but it just hasn't been thorough enough. And for whatever reason, Stephen Brearey in particular became fixated on Lucy Letby, and they were unable to adequately look at their own clinical care and identify the problems on the unit, probably due to a lack of ability, lack of experience, and for the unit not being up to the standard required. And of course, this has been emphasised numerous times. They're dealing with neonates. One of these 3 infants at the very least, and I believe 2 of them, should have been on a tertiary unit. And they're not even neonatologists. I'm sure they're capable paediatricians. I don't know. It's not for me to judge whether or not they're good at their job and whether or not they're good doctors. But in my view, a neonatal unit should have a neonatologist, and a level 2 unit definitely should. And a level 2 unit dealing with level 3 infants that's understaffed and underskilled with loads of problems that we're going to go over later in the video definitely should have a neonatologist. So then Caroline Cheetham continues. That didn't prompt anything else, I'm assuming, at that point. And then John Gibbs says no. And my feeling when I realised Lucy Letby had been involved in all this death was it was just very bad luck for her and how unfortunate for her. And understandably, at that stage, I think the senior nurses on the unit were very defensive of her. She'd been very unlucky. And it's stressful to be, unfortunately involved in several deaths close together. So then, looking at the raw data, the cold raw data, those 3 deaths in a short space of time could have been your annual number because that would have tallied with what had gone before. But as you said, if it stops there, we're fine. But in addition to it being unusual, there were 3 deaths fairly close together. There were some unusual features associated with those deaths, which is true. That's absolutely true. The problem is they couldn't understand what had happened. They couldn't understand why there were unusual features, and they couldn't understand the underlying problems. And it seems that some effort was made to do this, but perhaps they just lacked the skill set, the experience, and possibly just the knowledge and intellect required to recognise these things. When you put them in front of a panel of world-class experts, it's completely different. And also, I will say in their defence, they're obviously busy doing their day job. They do need to reflect on the desk, but they also need to deal with the other infants that are on the unit. So they may not have turned up all the problems that existed. I think it's very clear that they should have recognised more of the problems than they did, and they obviously quite clearly should not have become so fixated on Lucy with this completely unevidenced commonality that they became fixated with. I mean, particularly Brearey, but it seems that all of them did. It was when the deaths and collapses continued, and most of them were associated with some unusual features, that it raised great concern. Just remind us what those unusual features of the first 3 were, Caroline Cheetham says. And then Dr. John Gibbs says, unusual rashes and also unusual responses to resuscitation. Then Caroline Cheetham says, so they weren't responding in the normal way, or they were responding later. So it's interesting that Dr. John Gibbs, when asked what the unusual features are, he just says there are rashes, and they didn't respond as we expect to resuscitation. So at this point in time, I've just listed several problems. There are many others with those infants, but he has been given a chance here to say what is unusual about the collapse of these infants, and all he can say is, there were some rashes and they didn't respond to resuscitation as we expected. The reason they didn't respond to resuscitation as expected is because of the litany of problems and the catalogue of errors on the unit. That's why they didn't respond to resuscitation, but of course he hasn't recognised that. So as Caroline Cheetham said, so they weren't responding in the normal way, or they were responding later. Then Dr. John Gibbs said they weren't responding as you'd expect, really. Of course, as we've established, they weren't responding as you expected because you didn't understand what was happening. And it varied in different patients. Again, the reason it varied is because they had varying, diverse conditions and varying and diverse problems that you didn't recognise. Some of those responses to resuscitation that were unusual could be that there was no response at all, whereas you'd expect some sort of response, even if in the end it's not a successful resuscitation. Or for some babies, they responded unusually well. That seems like a really strange thing to say. Or for some babies, they responded unusually well. I've never heard that mentioned at any stage by anyone else. That seems a strange thing to fixate on, but anyway, I won't dwell on that at this point in time. I might ask someone who knows more about this than me, what is the relevance of that, or what is the significance of that. So then Dr. John Gibbs continues. That could be a transcription error, of course. They seem to collapse catastrophically, have a heart-lung collapse. There were cardiorespiratory arrests, and then seem to recover as though nothing had happened. So it's not a transcription error, and be temporarily almost back to normal. Now, in retrospect, and I didn't suspect this in the babies I was involved with, I don't think my colleagues did. If there's something like a large air bubble travelling through the circulation blocking the heart, then the baby can collapse catastrophically and could die. With all the resuscitation attempts, you can disperse that air and it pops out of the heart and the baby suddenly recovers. but we didn't realise that was happening. All we knew is these babies were responding in an unusual way, some not responding at all, and some strangely responding far too well. So he's now explained kind of what he meant. So let's just critique these comments. In this video, we will examine. So there's two statements that I want to just look at briefly from that previous passage. The first one is they seem to collapse catastrophically, have a heart-lung collapse. So, in fact, obviously the key term here is seem. They seem to collapse catastrophically. Now, the term catastrophically, obviously there were catastrophic collapses because there were terminal collapses and you don't get much more catastrophic than that. But the point is that, again, he is implying that they just suddenly collapsed out of nowhere, whereas that's not the reality of what occurred. Because we've looked at 3 infants already in this video, and it's very clear that they just simply, they made, to be fair with those infants, some fairly basic mistakes, and they missed some things that shouldn't be missed on a neonatal unit. And actually, the more that I've spoken to people, the more that I've spoken to nurses, the more that I've spoken to doctors, the more that I've understood what actually occurred on the unit, the more that it's become clear to me how rudimentary some of the failings were. But certainly in terms of diagnosis, in terms of attempting to understand the conditions that occurred in these infants, they were way, way under the standard required. And that's why Dr. John Gibbs can have this impression that seemingly that some infants had catastrophic collapses and some recovered as though nothing had happened and be temporarily almost back to normal. Of course, they weren't really back to normal. That's the point. They were still suffering with the conditions that hadn't been diagnosed. The body will fight. The body will fight illness. That's what it does. That's why we have an immune system. And even in a very vulnerable neonate, that can be powerful and it can keep the body alive and keep the organs alive. And just keep you going, even though you're in a critical condition, even though it may seem, based on the basic measurements and the basic readings and the basic data that they had in the unit, they may think, oh, everything's fine, when of course in reality it's not, because they're missing, as we've heard from Michelle, as we've heard from other people on this channel, they're missing the subtle signs of deterioration. So actually these collapses are not unexpected, they're just, the reasons for them are not documented. So there's also this comment about with the resuscitation attempts you can disperse the air and it pops out of the heart and the baby suddenly recovers. So I think the implication here as well is that they saved infants from some instances of air embolism and the deliberate injection of air, and that Lucy Letby kept trying. That seems to be the implication to me. Whether or not that's what he meant, I don't know. But that would mean an even more extraordinary series of events. But that's a relatively moot point. The important thing is that the word seem is really the key word here. What seemed to be the case to Dr. Gibbs and the other consultants wasn't actually the case in reality. In this video, we will examine. So Caroline Cheetham continues. It's the first time I've heard that, so the resuscitation attempts could almost pop the air bubble. I agree that didn't really come out, Liz Hull says, but there was talk in the trial of the kind of CPR efforts that went on for a long time and eventually worked, and nobody could work out why. I think baby M was one of those. And Dr. John Gibbs says it's not unusual not to respond fully to resuscitation because sadly, at any age, patients who deteriorate, particularly if they've got I think that will be unusual medical conditions that are overwhelming their body, when they deteriorate and have a cardiac and respiratory arrest, a severe collapse. It's not always possible at all to save those patients, but it's just that for babies that had appeared to be behaving normally, so appeared to have been, the observations were satisfactory to suddenly collapse, and then you can get no response and the resuscitation is unsuccessful. That's unusual. So it's a combination, not just that the resuscitation was unsuccessful, there was no indication why the baby collapsed in the first place. You can't always predict and you don't always have the answers. And very frustratingly for families of a patient who has collapsed and sadly sometimes died, it's not always possible to determine exactly why some patients have collapsed. So we don't have all the answers all the time in medicine, but it was the sort of developing pattern of repeatedly not being able to explain the deaths or having unexpected collapses. So I won't expand on any of that any further. But it's so tragic, odd, weird. I don't know quite how to describe it. Many different things. That because they couldn't explain the deaths, they just decided, right, well, it's got to be a nurse that's deliberately killing the patients. When there was so much known about the failings on the unit, and they were willing to completely discount that. They were willing to completely discount the RCPCH report. They were willing to discount the coroner, the pathology. They were willing to discount what they themselves knew about the physical failings of the unit. They were willing to discount all of that because if they were to look at any of that, then they could have been culpable. But they weren't willing to accept that. So they just decided, oh, well, it's obviously definitely a nurse that's doing everything. We just need to focus our efforts for the next 2 years on making sure that this is reported to the police. Fairly outrageous, considering that when it was referred to the police, it was referred with literally no evidence. So then Liz Hull continues, because then we heard, obviously, after those 3 deaths, that another baby died in August, and then another baby died in October. So you're kind of looking at 5 deaths in a fairly short space of time. And I think Dr. Brearey emailed managers at that point and said, I'm concerned about the spiking deaths. And the association with Letby was noted again. And I think at that point we heard that Alison Kelly, the nursing director, said, oh, we'll see, let's see what happens. And nothing was done again. And then you fast forward again to February. By this point, a specialist from the Women's Hospital had been asked to have a look at the run of deaths. And although he couldn't find a cause, again, the association with Letby was flagged. And that's, I think, when it became a bit more serious. Is that the reading of it from February? So what I'm going to go over here are a few important aspects of what has been stated. I will say that at this stage, Liz Hull, the documents from the Thirlwell inquiry have not been released. So although she's completely ignored those documents since they were released, she didn't actually have access to those documents at this time. But I want to look at a letter that was written by Dr. Murthy Saladi, one of the consultants on the unit. This is from, I believe, June 2016, and he says the following. Hi all, following the Monday meeting where we discussed about how to proceed further on the unusual number of unexplained deaths in the neonatal unit over the last year, here are my thoughts. We have investigated these deaths as much as we can, which included seeking clinical input from outside. The only thing which came out of it is one member of staff who was working in the unit, not necessarily the baby who passed away in each incident, but might have cared for the baby during the staff breaks at the time of all these deaths. This is highly unreliable information, and further outside clinical input is unlikely to help shed more light on the relevance of this information. So, I mean, that particular paragraph is a reasonable statement, but further clinical input could certainly have shed light on the reasons for collapse and death. But he's right that this is unreliable information. However, we seem to be acting on this unreliable information. We have moved this particular staff member, so this must have been in July, in fact, from night shifts to day shifts and from ITU care to HDU/SCBU care. When the pattern of the deaths changed, we are becoming, at least those who dealt with the babies during the resuscitation, those who have participated in the investigation until now and are aware of the outcome, even more worried about patient safety and their own mental well-being. This is affecting all of us in one way or other. This is unfair to the staff under suspicion, unfair to parents and other staff who are unaware of the situation, and unfair to the staff who are aware of the situation but worried about how things are progressing. I believe we need help from outside agencies who can deal with suspicion. At the moment, we are all under suspicion, and the only agency who can investigate us all, I believe, is the police. So I'm not going to continue with this any further because that's really the critical sentence in this letter. So Dr. Saladi is stating we need help from the police, but we should be under suspicion. And this is in July 2016. And they've already been waging a campaign against her for a year, and they've had her thrown off the unit now when the nursing staff and the nursing managers did not want this to happen. So it's fairly extraordinary that it took 10 months for it actually to be referred to the police. And as I've said numerous times, and I will no doubt say numerous times again in further videos, the sole reason this has occurred is because none of them had the guts to do it. They didn't have the courage. They knew that they'd be putting themselves on the line, they knew that they were becoming whistleblowers, and they knew that they weren't delivering any meaningful evidence. That's very clear, because 10 months later, when it is referred to the police, there's still no meaningful evidence. So none of them were willing to put their head under the guillotine and see whether it fell on them. It's as simple as that. That's the only reason, because they're going, we need to go to the police, we need to go to the police. But they could have done it. And not only could they have done it, but Dr. Saladi is saying here, we should go to the police and we should be under suspicion. Whereas what Brearey and Jayaram actually did is do it in the most cowardly way possible, where they risked absolutely nothing. They took the longest amount of time over it possible, and they also didn't supply any information, and then sort of surreptitiously sneaked into the police station and seeded them with a lot of what I would consider to be inaccurate information, frankly. So we know the picture of what it should look like if you're going to refer this to police, and we know the picture of what actually happened. Of course, I've been over this in previous videos, but Dr. Saladi here is making a lot of very fair comments, but these just weren't acted on. And then the last thing to say is, in the Thirlwell inquiry, it was established that Dr. Gibbs couldn't contact the police and didn't contact the police. Sorry, this is not in Thirlwell, this is during the court case. Ben Myers is interviewing him. And Dr. Gibbs says that was difficult. Nurse Letby seemed to be involved in all the cases that involved me. So as much as Dr. Gibbs is somewhat more reasonable than Brearey and Jayaram, when it came down to it, he wouldn't put his head in the noose either, because he knew he was involved in cases and he knew he could end up under suspicion. So all the consultants handled this so that the finger was pointed firmly at Lucy, and we know from that 15th of May meeting, as I've said numerous times, they identified Lucy. Undeniably, that is the case, while having referred the case to the police in the most cowardly way possible, and then they all took the credit for being whistleblowers, particularly obviously Brearey and Jayaram. In this video, so Dr. John Gibbs continued responding to the statement of Liz Hull. Is that my reading of it from February, she said. Dr. John Gibbs says, yes, I think by October suspicions were just beginning. Could it be anything to do with Lucy Letby? Because as we said before, it was noted for those early deaths around June and July that Lucy Letby had been involved at the time of their deaths, but that was felt to be just a coincidence and bad luck at that time. So there's the term coincidence there. As we know, when this was passed to the police, there was still, in that infamous phrase that I repeat so many times, no evidence other than coincidence. That was in May 2017. When she continued to be associated with some deaths and collapses, and those deaths and collapses in various ways seemed unusual, not always but sometimes completely unexpected, that then started to raise dark suspicions that Lucy Letby could be doing something. But again, no one knew what it was she was doing. No one saw her doing anything to harm a patient. But it was by February, when these collapses and deaths were continuing, that a review of all the deaths since the previous June was undertaken, as you say. An experienced neonatologist consultant in newborn care came to the Countess of Chester Hospital to review the deaths, and he'd looked through the paperwork and the records beforehand, and it was noted that some of these deaths seemed unusual. That was the opinion of the outside neonatologist, but he also highlighted her presence, didn't he, that Lucy Letby had involved in all of them. So I think there's a bit of a mix-up with the transcript there, but it's a question that's being put by someone. So let's just pause and think about the neonatologist a second. So the consultant seemed to become very fixated, as did the police later, on the idea that these deaths were unusual. But there was no evidence of foul play, and what should have happened was more medical investigation, because there were explanations for some of these deaths. And if there'd been more effort to review the circumstances around them, and if indeed the hospital had been more honest with these external actors and made it clear to them the problems on the unit, then those causes may have been more readily recognised. The hospital didn't do that because the hospital didn't want to be found guilty, essentially, of being substandard. Obviously, we know it's substandard, we know it was downgraded, and probably there's a chance it'll never be upgraded again. It certainly hasn't been so far. So it's fascinating to me, perverse, I suppose, that Dr. Gibbs can't seem to accept that there could be a medical explanation for these deaths, because they were examined and they couldn't come to 100% definitive explanation. Well, that's not out of the ordinary. Definitive explanations were given for several infants, and we know that some of those were correct. So it seems very strange to me that they just had this complete fixation on the notion that some of these deaths were unusual. The reality is that they were unusual. There were a catalogue of health conditions. There were a catalogue of problems on the unit. There were a catalogue of mistakes. There were all the things that we've been over in these panel reports. That's why the deaths were unusual. So let's move on. Caroline Cheetham says, yes, you talked about dark suspicions by October 2015, while it had begun to emerge. Then how does that manifest as a group of experienced consultants? What are you saying to each other? Dr. John Gibbs says, well, I say we were only beginning to wonder whether there might be some worrying association, not just that Lucy Letby just happened to be there, but why was she there each time these unusual collapses were happening? The main concern at that stage was that we were having an increasing number of deaths and collapses, and we were still looking and searching for clinical, normal, ordinary clinical reasons for that. And we kept asking ourselves, we didn't have to be asked this repeatedly by the defence barrister during the trial, we were asking ourselves, are we doing something wrong? Are our procedures and practices failing in some way? Why is this happening? But there was nothing. So let's reflect for a second on whether or not there indeed was nothing to indicate that anything was wrong with any of their practices or anything was wrong with the unit. So move on to the preview report from the panel, which includes these 25 criticisms of things that occurred on the unit, general practices, sanitary conditions, some major things, some slightly smaller things. And this isn't an exhaustive list because there's individual criticisms within some of the infant cases as well. I'm not going to go through and read all these out, and I'm not going to read, because I've done it previously, and I'm not going to read out all the individual criticisms from the infants as well. And there's probably further criticisms in the final reports. Then on top of that, of course, we know that the hospital, the Countess of Chester, suffered a lethal bacterial outbreak of Pseudomonas. And there's a relationship between this bacteria and sepsis. We also know that the Countess of Chester knew about this. Then, of course, we know that there's essentially endemic sepsis on the unit, with 9 of the indictment infants suffering with sepsis, and also the third insulin case infant, sometimes referred to as child Y, also suffering with sepsis. This is why the neonatal unit was downgraded. When the neonatal unit was examined by the Royal College, they found a litany of problems, and they were very critical, and that's why it was downgraded. And as you can see on the screen now, it remains downgraded, and they wouldn't be able to deal with numerous babies that were in this court case. As it was, even as a level 2 unit, there were several babies they shouldn't have dealt with. But now, I would say even the majority of them could not be born on this unit and could not be treated on this unit. So, just to summarise this briefly, there are documented issues on the neonatal unit at the Countess of Chester with transportation, sewage, sepsis, Pseudomonas, other bacterial infections, level of staffing, level of experience, the amount of space on the unit, the quality of practice on the unit, and the physical standard of the ageing unit itself. Indeed, the unit has since been closed down. So, as I say, it's not at all unfair, and indeed it's accurate to describe this as a catalogue of problems. So that's why they were struggling, that's why the babies were struggling, that's why they were having subpar outcomes. And this is what I mean about in the court case. He has just acknowledged, and I've stated this myself, a lot of the court case is just people from the Countess of Chester being cross-examined and them saying we couldn't see anything wrong. But the reason they couldn't see anything wrong was because they were A, biased, and B, incompetent. And they couldn't recognise, for self-serving reasons and also just for reasons of practical ability, they couldn't see the problems that were inherent on that unit. But we now know about all of the problems, and the jury never heard about that. The jury didn't even hear the Royal College report because the judge, in his infinite wisdom, decided that it was irrelevant. So maybe the judge would look at all this and decide that was irrelevant as well, if it had been available at the time, and rule that out the court case. But what we can say definitively is that the jury never heard any of this. In this video, we're continuing from the highlighted section, and we'll see in this next passage that they did actually identify some of the problems, but it was relatively minor things. There was nothing that explained the deaths and collapses. Clinical care doesn't always proceed perfectly all the time for every patient, and in reviewing the deaths and collapses it was noted that on occasion antibiotics hadn't been given quickly enough, on occasion infection hadn't been diagnosed early enough. There are certain medicines that premature babies need to help their lungs when they're very stiff, and on occasion, not every time, just in the odd patient, it wasn't given early enough. So there were always things that we could have improved in our practice. We didn't think any of those that I mentioned actually caused the death, but they may have contributed to it. So then, I'm not going to reflect on that too much. I mean, I've already explained the issue here. Caroline Cheetham says, okay, at that point then, from October to sort of February, what was the atmosphere like on your unit? How was it working there? It was a little tense, but every neonatal unit is busy. There's a lot going on. There are a lot of babies who are quite vulnerable with very special needs, and most of your effort and thoughts are directed to doing the best you can for the babies. I don't think most of us, I wasn't at that time worrying about Lucy Letby most of the time. There were dark thoughts at the back of your mind, and then sadly, we were hoping that because these deaths were being reviewed in the risk management review structure, these concerns would be addressed through that means. So Liz Hall says, and so do you think then the very nature of a neonatal unit being busy helped to do what she did because people, were maybe distracted? So, I mean, I find it extraordinary. This is one of the most extraordinary accusations even in this extraordinary court case. The idea that Lucy recognised that it was a busy and failing unit, so then she started bumping off babies because of this, and somehow that shielded against her from anyone noticing anything. Although they had noticed stuff because they targeted her, basically. When I say targeted, they had strong suspicions immediately. Dr. Brearey immediately looking for commonality. So the idea that this all went on surreptitiously, undercover, without anyone knowing, that's true in terms of anyone seeing anything, absolutely. But the fact is the consultants were ganging up on her well before she was thrown off the unit, let alone arrested by the police. So it's not quite true that, we never suspected a single thing, and then, hey, we had to come to the horrible realisation. That's just not a realistic representation of what occurred. So Dr. John Gibbs continues, yes, I think that's quite true, and that Lucy Letby herself didn't behave abnormally, as far as I could see at all on the unit. She was quite quiet and she seemed conscientious, and no one saw her do anything to harm a patient. So she is quiet, she is conscientious, and she didn't do anything to harm a patient. That's why you saw all of those things. And that helped her operate in plain sight, like we've talked about, and go under the radar. Essentially, yes. When is the first point at which managers you feel should have acted? I know that it's been pointed out that the association with Lucy Letby was noted after the first 3 deaths. So by July 2015, I don't think any of us were, certainly speaking for myself, really thought that anything suspicious was happening at that time. It's different in retrospect when you've looked at what's happened over the year. When you look back at those deaths and discuss them in court, yes, we were very worried about them. We were concerned about Lucy Letby's association with them. But that concern was because of what had happened over the subsequent months, not at that time. So I'll just repeat that this is somewhat inaccurate. The managers couldn't have done anything at that time. It would have been inappropriate for them to have taken further action at that time. So what I will say in addition to that is you never coughed up any evidence for them. That's why one of the major reasons they were reluctant. They expressed that to you and to Brearey and to Jayaram, and you still didn't give any evidence, and there still wasn't any evidence even after the executives had agreed to refer the case to the police, and then there still wasn't any evidence when the police received the case. So to say the managers should have done something is pretty much entirely unfounded. So then it continues, it would have been inappropriate for them to have taken further action at that time. I feel probably the same applies to around October 2015 as well. We were not saying to managers, we think someone might be murdering babies on the unit or trying to murder them in October. By February, when an external experienced senior paediatrician or neonatologist had come to help review the deaths with Stephen Brearey and some of the nurses in the risk management team, concerns were highlighted at that stage. So we're on February 2016. Is that the point at which management should have listened? So this is way before any evidence was produced. This is 15 months before they produced any evidence. It's possible that Dr. Evans would have been busy at that time. He could have gone to the police in February 2016. A competent expert could have walked in, or maybe they wouldn't have been able to find an expert at all, and this could have all been avoided. That ultimately could very well have been the consequences of this being referred earlier if any of the consultants had the courage to actually refer the case to police themselves. which Dr. Brearey, despite running this 2-year campaign that we talk about, he himself never had the courage to go to the police, even though he was going on and on and on about it. But he never. There were two things that he never did: A, produce any evidence to the hospital until he walked in, or the police until he walked into the police station on the 15th of May, and B, make any effort to contact the police himself until he'd been referred by the hospital. So, as I say, they manipulated the situation as much as they possibly could, and they took the absolute bare minimum amount of risk, i.e. none. So then Dr. John Gibbs says, well, that was a point at which concerns about the number of deaths, the nature of some of them, and the association with Lucy Letby were made not just by Stephen Brearey, supported by the rest of us as paediatricians, but also by an external paediatrician who'd come in to help review the deaths. So that's complete rubbish. The external paediatrician who came in to help review the deaths did not support the position of the consultants whatsoever. I mean, that's just blatantly untrue. Nor did the Royal College, nor did the coroner, nor did Dr. Joe McPartland, who also reviewed the deaths. So that's just categorically untrue. I don't know if he genuinely believes that to be true. I don't see how he possibly can, but I mean, it's certainly an untrue statement. So Dr. John Gibbs continues. So through the clinical risk management structure and what these meetings were, those concerns were fed back to the Director of Nursing and Medical Director, and because it was his role, Stephen Brearey had passed those concerns on. And this all continues. And I think he said that he asked for an urgent meeting and he had nothing back for 3 months. Now, I wonder amongst the consultants, I mean, you were asked in court whether you should have gone to the police at that point. Is that a regret now for everyone? Yes, I'm not certain that we should have gone straight to the police in February or after February 2016, but I do accept that maybe we could have done that. I realise I've missed an opportunity there to say that Liz was in court, so I'm sorry about that. And sadly, at least 2 lives would have been saved if that had happened. Yes, there's always a bit of time delay between contacting managers when they can arrange a meeting and so on. It really shouldn't have been 3 months, but I mean, it could be a few weeks. It depends on the nature of those concerns. Of course, the nature of the concerns was a matter of grave importance. So then Dr. John Gibbs says, yes, but the managers need to answer for themselves and they need to explain what they did and why they did it. So I can explain this for you. Quite simple, really. No one gave them any evidence, so therefore they couldn't go to the police. Even though they ultimately did go to the police with no evidence and asked them to exclude unnatural causes, and the police acknowledged that there was no evidence. That's the answer. It's a very straightforward answer, and it's all come out in the Thirlwell inquiry now. I would imagine, particularly in the way they behaved after that perhaps by this stage they'd already decided or felt that the concerns we consultants were raising about Lucy Letby were unjustified. Well, no. They explicitly stated and explicitly requested for Brearey and Jayaram to produce evidence. Now, Dr. John Gibbs was not as centrally involved in this. Of course he was involved because one of the Gang of Four, and Brearey and Jayaram did manage to convince him about Lucy Letby, but he was not as centrally involved as Brearey or Jayaram. So he's not going to be necessarily privy to everything, but he's certainly aware and he certainly knows that they didn't produce any substantial evidence, and that's what the executives were requesting. I believe they were being given strong reassurances from the more senior nursing side on the neonatal unit that it couldn't possibly be Lucy Letby doing anything to harm patients. So basically what happened here, John, is that the nursing staff and the senior nursing side, as you describe it, the nursing managers, they have no reason to believe that Lucy Letby has done anything wrong. As you said yourself, no one has seen anything do Lucy Letby wrong. No one has seen Lucy Letby do anything wrong. As we've established, you never provided any meaningful evidence. In fact, you didn't provide any evidence at all. And the nursing staff are therefore not unreasonably saying they did describe it as a witch hunt on the unit. I believe it was Karen Rees that said that. It may have been Ariane Powell, but I believe it's Karen Rees who described it as a witch hunt. And she was absolutely right. So put yourself in the position of the executives. The executives have got the consultants on the one hand saying, we think this nurse is responsible for deaths on the unit. Okay, what's the evidence for that? We just think it's the case. What's the evidence for that? Can you give me any evidence? We're not giving you any evidence. What about your drawer of doom? Well, I'm not giving you anything from that. Okay. And then they go. The same executives go to the nursing staff. The nursing staff go, this nurse is highly regarded. The nursing staff really like her. She has a good presence on the unit. Her practice is good. She's written some of the policy for the unit. She's worked in a tertiary unit, which other nurses haven't. We like her. No one's seen her do anything wrong. There's no way that we're going to allow this. So the executive, naturally, he's got one side saying we blame Lucy Letby, and he's got another side saying we're here to defend Lucy Letby and we believe in Lucy Letby. And the side that believes in Lucy Letby is providing evidence for that, and the side that wants to blame Lucy Letby for everything happening on the unit has provided no evidence. So what else could the executives possibly do? I pose you that rhetorical question. So then Caroline Cheetham says, so by this point then there's a real conflict between the consultants, senior nurses and managers. Again, you talked about it being quite tense back in July 2015. How was it at this point? It was getting more tense on the unit. Not surprisingly, John, you'd have to say. Working with her, when you were sort of cold and she was in that room, did your heart sink? A bit later, it did. Yes, there was a feeling of doom that something was about to happen again. But now we know that the trial is over. We know that we know what Lucy Letby was doing. We did not know she was doing that. We did not know how she was. Hindsight now, absolutely. And I think the poor parents will think, why on earth didn't we just drag her off the unit and go to the police ourselves? Why didn't you go to the police, John? Why didn't you go? Why didn't Stephen Brearey? He was literally obsessed with the police. Did he not know the telephone number for the police? Was that the problem? But we didn't know what was going on at that time. It's a difficult discussion. Actually, on reflection, they have a lot of problems with telephones because they don't know the telephone number for the police, firstly. And then secondly, Dr. Jayaram doesn't know how to use a telephone at all. Because when he was speaking about Child K, he said we weren't trained on how to escalate something. Basically what you do, Ravi, is you pick up the phone, you phone the police. I mean, it is difficult for you because Dr. Brearey doesn't know the number for the police and you don't know how to use a telephone. So between the pair of you, you were in a bit of an invidious situation. But if you'd Googled it, I mean, I think there probably will be instructions online about how to use a telephone and how to phone the police. And I couldn't tell you the number for the police off the top of my head, but I hear that it's not that difficult to remember once you've read it for the first time. So Dr. John Gibbs continues, we'd had discussions amongst our paediatricians on and off over the coming months after Lucy Letby had left the unit and the manager or the hospital system was not involving the police. We did keep asking ourselves, are we sure what's happened? Do we know that Lucy Letby has done this? Are we being terribly unfair? Now, I can easily believe that Dr. John Gibbs has done that because he seems more reasonable than Jayaram and far more reasonable than Brearey. I see no evidence in the Thirlwell documents that Dr. Brearey did that or Dr. Jayaram did that. They had this fixated notion in their head that Lucy Letby was to blame, and they absolutely focused on that at the exclusion of everything else. That's my impression from the Thirlwell documents, and I've read every one. Not particularly or just to Lucy Letby, which would be awful to accuse someone wrongly, but also the fear of what we were going to do to these families by raising suspicion there could have been criminal activity, murder of their babies, and we got it wrong. But during the discussions it became clear that even if we had got it wrong, if we had that suspicion, what can we do? Ignore it? Sit on it? Or who are the people that can investigate it properly? We realised after a time, much later on, the only people that can investigate it properly were the police. So again, this is disingenuous because I've just read you the letter from Dr. Saladi. That email was sent to all of the consultants, as you would expect. Dr. John Gibbs saw that email, Brearey saw that email, Jayaram saw that email. That's undeniable. It took them 10 months from that point to refer the case to the police, and they didn't do it. It was the hospital that did it, and they just sidled in there, Brearey and Jayaram, on the 15th of May, 3 days after the police had already concluded there's absolutely no evidence of any malfeasance, and there's absolutely no basis to have a criminal investigation. But let's continue. After Lucy Letby had left, been removed from the neonatal unit, there were various other investigations. Internal ones in the hospital, one's by the Royal College of Paediatrics, one by another neonatologist from London looking at the deaths. And there were others as well that he hasn't mentioned. What we've learned in hindsight from all of that is none of those investigations were properly designed, equipped or competent to look at criminal activity. But they shouldn't have been looking at criminal activity. This is what I can only describe as a ludicrous assertion that all of these reviews should go in and specifically look for criminal activity. Of course, that's what Dr. Evans did. He spent 5 years trying to find criminal activity at the exclusion of everything else. That is not what medical reviewers should do. Dr. John Gibbs should know this. He's not a stupid person. He should know that the Royal College of Paediatrics, you're not supposed to prompt them. They did. They did prompt the Royal College of Paediatrics. They were told about the suspicions of Lucy Letby before they did their review. So obviously the RCPCH, I believe, headed by one Nina Modi at the time, naturally they went in and did an objective job. They didn't look for malfeasance where it didn't exist. It's not their job to look for criminal activity. It's their job to try to ascertain why infants have died. And any kind of preconceived notion or preconceived ideas that are introduced into the investigation imbues it with bias. Indeed, as the Royal College were informed about Lucy Letby before their review began, it was already not an ideal study. But even despite that, they still found absolutely no evidence Lucy had done anything wrong. And when they interviewed her, there's a 2-page statement in the report that I've read out previously that essentially just contains glowing praise for Lucy. So again, this claim here made by Dr. Gibbs it's not even tenuous. It's just balderdash, poppycock, bullshit, however you want to put it. So this all continues, and crucially, what was missed again was the fact that another baby had been poisoned with insulin, and again that test was missed. And you can't help but think if the significance of those blood tests had been seen, that it would have had a different slant altogether on your suspicions. Yes, one of the strongest pieces of evidence in the trial was the fact that 2 babies were found to have been given insulin, and I have to admit, we missed that on the neonatal unit. And when I say we, I mean all of us consultant paediatricians. A difficulty though, just to explain the insulin results, because they were so important. The results come back many days, and in one case a week after they'd been taken. Each of those babies had recovered from their low blood sugar and were not causing concern at the time the results came back. But it wasn't as though those tests were ignored. They were looked at and they were misinterpreted. So we're going to look back now at what was said in court, some critical information in relation to this. So we see here, this is from the Thirlwell inquiry, analysis of the blood sample showed low C-peptide to insulin. This caused the laboratory senior clinical scientist Heather Wilshaw-Jones to call the trust and speak to the Countess of Chester biochemist. The laboratory were not in possession of the clinical details and did not know whether insulin had been prescribed for child F. The note made by Ms. Wilshaw-Jones of her call states, low C-peptide insulin exogenous suggests sent a sample to Guildford for exogenous insulin. So it's untrue to say that the hospital was unaware of this at the time. They were made aware of it, they just didn't do anything. And then there was this bizarre exchange that occurred in court between Asbury, this guy Philip Asbury, who doesn't appear a great deal but is part of the prosecution, and Dr. Anna Milan. So I'll just read this out. Just one matter arising, doctor, with regard to Guildford. So I understand it. Would Guildford assist with whether it was exogenous insulin or not? No. The results dictate that it's exogenous. They would just help if you were unsure of the source. So really, Guildford would have been deciding or assisting with exactly what type of exogenous insulin, yes. Not whether it was exogenous or not, correct. So I have absolutely no idea why Dr. Anna Milan said this, but we know for a fact this is completely incorrect. It's known to be the case that the test that was used is not suitable to decide whether or not it was exogenous insulin, which is the whole reason that Guildford exists and the whole reason that the laboratory expert was phoning up the Countess of Chester, suggesting that they send it to Guildford so they could do the proper forensic tests to determine whether or not exogenous insulin had been used, as I've discussed in previous videos. So this was yet another thing that the court didn't hear about, and not only did they not hear about it, they were given massively misleading information. In this video we will examine... So Dr. John Gibbs continues, I think that's one lesson that needs to be learned, but it's not a quick, easy fix. The instant results are complicated. They don't come back with a normal range saying this is high, this is low. Lucy Letby didn't use insulin in most of her cases, as far as we're aware, and it's not. We did not mention insulin levels in every baby. But we do know, sadly, from the occasional healthcare professional in the past trying to harm patients, insulin is one of the ways that several healthcare people have tried to harm or seriously harm patients in the past. That is why looking at how we interpret insulin results and how the labs report them is important. So everything he said there is absolutely true, but of course it's actually important from the point of these things being miscarriages of justice. So there are some further passages that I want to look at from this interview. I've cut out quite a lot because there's a lot of now just waffle that's not really of any interest. but I've picked out a few passages from the remainder of the interview that could be of interest. So firstly, Dr. John Gibbs says, writing a letter of apology seemed inappropriate, but the whole of that meeting shocked me, so I wasn't really sure what was going on at that time. At the time we were asked to write that letter, we didn't feel it was justified. We didn't feel it was appropriate, but because we'd been asked to draw a line on this issue, we felt we weren't going to stop. We expressed our concern that these are natural deaths, but we could at least write the letter. That these weren't natural deaths, I assume. We didn't apologise for raising those concerns at all. We didn't say anything about whether we felt those concerns were true or not. We merely apologised to Lucy Letby for any inappropriate comments that may have been made, and also for the distress that had been caused by raising those concerns. But in a way, we just did that to comply with what we were asked to do. We had no intention of stopping pushing those concerns. So I'm sure many of you, as you're hearing this, will be very angry about that particular passage and will consider it to be quite despicable. I don't think it really needs an enormous amount of commentary from me. So Liz Hull continues. So there's a sort of comment here from Liz Hull. This is not necessarily how it occurred in the podcast. I've just picked out a few sections. So why did the managers not want the police involved when it was something so serious, so devastating for the confidence in the community? So obviously, I've answered that question numerous times. And you know women having babies in Chester. My kids were born in Chester. So I've heard people mention this with regards to Liz Hull. This is the first time I've encountered this in a podcast, so I didn't know whether or not it was true. I believed them, but I didn't know it for myself. So now this all starts to begin to make sense, does it not? That Liz is so heavily invested in the guilt narrative and won't look at anything that... Now there's an enormous amount of information that contradicts that, and yet Liz is completely impervious to that. I believe that someone who posts online on Twitter, I'm sure this person is familiar to you, is strongly affiliated with Chester and certain organisations in Chester as well. It's rather sad that they have this kind of, oh, my child was born in Chester, I live in Chester, I grew up. Yeah, it's just a town. Things can go wrong. Just because you live there, it doesn't mean that things can't go wrong, or just because your children were born there. It doesn't mean that... It's not like devaluing your children just because your children were born in Chester and there's a hospital there that's not very good. That doesn't mean your children's lives have less value. It doesn't mean anything. But it does seem significant to me that her children were born in Chester and she's so virulently come down in this way, in such an absurd way now. So she has become this ridiculous figure, and obviously I'm going to make her look more ridiculous in future videos, but it's not difficult because they have to engage in Olympic standard contortion to make this look like a guilty case at this point. And if she had anything about her as a journalist, she would be producing more balanced, at the very least, more balanced work by now, which of course she isn't. And I've always wondered why, and I have my own personal theories on it, but is this fact that Liz Hull's children were born in Chester, is that significant in her blinkered outlook and a complete lack of objectivity? It's impossible to say, but it must be a distinct possibility. So anyway, she says, you've got to have confidence in your service. That surely is worse than a bit of bad publicity about a police investigation that who knows could have turned out to have found nothing untoward. They didn't know at that stage, did they? So this is not realistic from Liz at all. Now, she doesn't know, in her defence, that the consultants had no evidence, presented no evidence, all the things we've been over several times. But yes, if you refer a case to the police saying, we think that a nurse is guilty of harming these patients, and we're referring the case to the police for that reason, which is exactly what Brearey and Jayaram did, and then say Dr. Evans had been working on another case or hadn't been available or had never heard about it, and they brought someone else in who's more circumspect, and they looked at the notes and said, well, I don't see any evidence of malpractice on behalf of any nurse. I don't see any malfeasance. I can't necessarily 100% explain all the deaths, but there's nothing to say that there was anything unusual or out of the ordinary, and there's not satisfactory evidence to launch a police investigation. Then, yes, That would have been a little bit more than a bit of bad publicity, Liz. That would have been an enormous embarrassment. There'd have been all kinds of problems. There'd have been massive problems for the consultants. That's why the consultants didn't want to refer it, because it could potentially have been the end of their careers, or at the very least, they could have been badly damaged by it. That's why they don't go to the police. That's why, even when Dr. Saladi writes that letter in July, and he is the one who's brave enough to do it, and he if he was braver still, he could have pushed for them to go to the police at that time, but yet it took 10 months, and then when it did happen, it wasn't the consultants writing to the police. My simple answer to your very appropriate and challenging question is, I don't know. From what I've heard, from what I heard at that time, and what I've heard from my colleagues who'd been involved in some of the meetings, I wasn't at some of the meetings I was involved with, I think the managers who really do need to answer for themselves, and an inquiry will give them the opportunity to do that, probably could not accept and just could not believe that a member of staff could be killing a series of patients in the hospital. It's not that they couldn't accept and couldn't believe it. If they're going to accept that or consider it, they need significant evidence. Otherwise, anyone can just say any time about anyone, I think they're killing patients, you should refer them to the police. Now, although Thirlwell are putting some... It could be they're going to put some ridiculous recommendations in place in relation to this. Anyone can see that that's extremely dangerous, because anyone can just have a bit of a vendetta against someone, or someone can just piss someone else off and they can go, right, I'm just going to shift them to the police. And if they're expected to take it seriously without any evidence, surely I don't have to explain why that's dangerous. They just couldn't believe it was possible. I don't have direct evidence of this, but I've been told that some of the senior nurses were very strongly defending Lucy Letby, and they just couldn't believe she could have done anything. They didn't have any evidence, John. You didn't have any evidence, and you wouldn't go to the police. So I think they closed their minds to the fact that she could have done that too soon. Let me remind you as well, Dr. Jayaram is supposed to have seen Lucy Letby attempting to murder a baby at this point, by July, 5 months previous to this. And he only remembers in the police meeting in May, I think it's approximately 450 days after he's witnessed it. It is a shame that, despite all of us consultant paediatricians expressing concerns, that our clinical experience and our repeated observation that these deaths were outside our normal experience, that they were unnatural and unusual in different ways, that advice wasn't heeded, because it's not enough. You can't just say, well, we think these deaths are unusual and unnatural, so therefore you should go to the police. That could be what the Thirlwell inquiry is about to recommend. If it does, that is insane. It's immensely dangerous. It will be calamitous. But I think the managers need to answer for themselves, because I know what the paediatric consultants were telling them. I don't know exactly what other people were telling the managers and what other advice and information they were getting if they were receiving it from elsewhere. So now just the final two comments. So something you said before we recorded it surprised me actually, because one of my questions to you was going to be, do you feel vindicated? Actually, you made the point that you feel some of the families may not forgive you. Maybe, yes, we could have gone to the police and bypassed all the management structures and just gone straight to the police. At the time, we were doing the right thing. In retrospect, maybe we could have done more. So, of course you could have done this. You could have picked up the phone to the police at any moment and bypassed the management structures if you felt strongly about it, if indeed you had any evidence, but you wouldn't do that. Dr. Saladi wrote to all of you. You definitely saw that email. Dr. Brearey definitely saw that email. Dr. Jayaram definitely saw that email. None of you would act on that and didn't act on it for 10 months. And the reason is because you didn't want to put your head on the chopping block, because you're cowards, basically. It's as simple as that. There's no reason for you not to go to the police. If you're saying, oh, the consultants should have paid attention to us. The executive should have paid attention to us. So if you believe the executive should have paid attention to you, then you could have done something yourself. If you felt strongly enough about it that you believe the executive should have acted, then when the executive didn't act, you should have done something, clearly. And there's absolutely no reason for you not to do it, and there's absolutely no reason for you not to produce evidence. The simple reason is you didn't want to do it because you wanted to protect yourselves. In this video, we will examine... So in summary, there are essentially 4 key themes that come out of this podcast. The first one is that Dr. Gibbs, in common with other consultants, failed to understand medical symptoms and signs of deterioration and interpreted this as collapses being unexpected when what they were was misdiagnosed or even undiagnosed. The second thing is that Gibbs claims throughout that the executives should have gone to the police sooner, but fails to acknowledge that the consultants gave them literally no reason to do so. The third theme is there was nothing stopping Gibbs or any of the other consultants from phoning the police themselves. Even Gibbs tacitly acknowledges this. I can only assume the reason they didn't do this, as Brearey in particular completely fixated on it, was that none of them had the courage to do so. And then finally, we know that Dr. Saladi wrote to all of the other consultants expressing his very explicit view that the police should have been contacted in July 2016. This letter was completely ignored, and the following ultimately occurred. The case wasn't passed to the police for another 10 months. When it was finally passed to the police, this was not done by the consultants. The case was passed to the police with literally no evidence, which of course is why the executives didn't want to contact the police in the first place. So overall, it was a fairly interesting interview given what we know now. I won't make any further comment on it. I'll just ask for your reflections in the comments section as always, which I'll look forward to reading.